All right, are you ready to talk about orthopedics? Okay, let's start with fractures. And the first thing we always start with, signs and symptoms. All right. Now with fractures, we have pain and tenderness, okay? Pain and tenderness. Also, you may see unnatural movement. Unnatural movement or deformity, all right? A lot of times you can just look at someone's leg, for instance, and you know it's broken because their foot is pointing backwards, right? Okay, you know what I mean. Also, shortening of the extremity can occur. Shortening can occur because muscle spasms will cause the extremity to shorten. Now, crepitus. Crepitus is when those bone ends are grating together, or it may be cartilage rubbing together. Now, it may be a feeling or it may be a sound, but like I said, it's the bone ends grating together, or it could be cartilage rubbing together. Now, when we get to the respiratory section, you will see us use this term again, all right? Crepitus I'm referring to. And when we get into the respiratory section, crepitus is going to mean air in the tissues, and we'll talk more about that later. Also with fractures, swelling and discoloration can occur. Now, that kind of scares me. Swelling and discoloration is what I'm talking about now. Because when I see swelling with a fracture, I know they might be about to develop a major problem. What is it? Yes, compartment syndrome. Compartment syndrome, and compartment syndrome really scares me because can this cause you to lose your extremity? Yes, and we're going to come back to compartment syndrome in just a little bit. But first, let's talk about treatment for fractures. First, immobilize the bone ends plus the adjacent joints. Now, I said the adjacent joints too because we want to move this very little. Support the fracture above and below the site and move the extremity as little as possible. All three of these things are to prevent further injury. Prevent further injury. Also, splints are very important because they help to prevent fat emboli and muscle spasm. Fat emboli and muscle spasm. Now, what do we do with open fractures? Well, if the bones are actually sticking out, what is one of the first things you need to do? Cover that wound, right? Cover those bones. You need to use something sterile if you can, but if you can't, just use something as clean as possible. Now then, let's say you go back into this client's room and the bones have disappeared. They're gone. What's happened? Muscle spasm caused those bones to pull back inside the body. Well, that's bad because when they pull back inside the body, what did they take inside the wound? Infection, bacteria, okay? Now, the most important thing in the whole world with orthopedics is neurovascular checks. That's right, neurovascular checks. Now notice, it's not just neuro checks and it's not just a vascular check, it's both of them, right? It's neurovascular. Now, out of all of those things you see on your handout, pulses, color, movement, sensation, capillary refill, and temp, which two are considered neuro? The neuro component. Movement and sensation. Yes, movement and sensation. Now, remember, we said in burns that the sensation could go either way, right? Okay, it might be neuro or it could be vascular. But for orthopedics, I like to keep it with the neuro check. Now, let's move on to complications. First one you see there, shock, hypovolemic shock. You know, you can bleed depending on the amount of trauma and the type of injury, right? The amount of blood that is lost is going to depend on the type of injury and the amount of trauma. But I'm worried about shock specifically with pelvic fractures, crushing fractures, and multiple long bone fractures. Now, a fat embolus is a biggie with fractures. With what type of fractures do you see a fat embolus? The same fractures that can lead to shock. Your long bones like your femur, pelvic fractures, and any crushing injury. Now let me repeat that. Long bones, pelvic fractures, and crushing injuries. All right. Now, the symptoms of a fat emboli depend on what? Where the fat embolus goes. Now, we discussed that in the respiratory section. We discussed all the different places an embolus can go. A fat embolus likes to do the same thing, all right? Now, on the handout, I've written down for you some unusual symptoms you see with the fat embolus. And the first one is petechiae, or rash over the chest, caused from embolization of skin capillaries, all right? Embolization of skin capillaries. Also, conjunctival hemorrhages may be seen where they actually start bleeding into the conjunctiva of the eye. Now, that's a little different too, isn't it? Yes. And another one you may see is called a snowstorm on the chest x-ray. Now, I bet when you read the chest x-ray reports, you have seen or read the terms patchy infiltrates. Patchy infiltrates. Or maybe when you've actually looked at a chest x-ray, you might have seen white fluffy stuff all over the lung fields. Well, that's called a snowstorm when you're dealing with a fat emboli, all right? A fat embolus likes to go to the lungs. That's one of its favorite places to go. Now, some other points I want to make about a fat embolus are this. First of all, the people that tend to develop a fat emboli are young males. Now, why is this? Because they engage in riskier behavior, whether it be motorcycles, dirt bikes, snow skiing, rock climbing. Now, I know females do that too, but males tend to be a little bit more riskier, okay? So they have more injury. Another fact is this. If you're going to get a fat emboli, you're probably going to get one in the first 36 hours after the injury. That's your danger time. If you can make it through the first 36 hours, you probably are not going to get a fat emboli. But you might get a pulmonary embolus, okay, or a deep vein thrombosis. Now, the next complication, compartment syndrome. Now, what comes to mind here is, I wish I could have prevented this. We want to prevent compartment syndrome if we can. Well, first of all, what is it? It is increased pressure within a limited space. Okay, so here we go. Let's look at the patho. Fluid accumulates in the tissue and impairs tissue perfusion. That is why we elevate fractures, because we do not want this fluid to accumulate, okay? Next, the muscle becomes swollen and hard, and the client complains of severe pain that is not relieved with pain medication. It is not relieved with pain medication. The pain is unpredictable, and it is disproportionate to the injury. They have more pain than you would normally expect, depending on the injury, of course. Now, if it's undetected, it may result in nerve damage, and possible amputation could occur. Now, common areas for compartment syndrome are the forearm and the quadriceps. Forearm and quadriceps. Now, also, I want you to understand something. You do not have to have a fracture to get a compartment syndrome. It's just that whenever we're studying compartment syndrome, it's always in the fracture chapter, okay? But you can get it other times. I've seen people who were in, for instance, a car wreck, and they had an injury to their arm. Wasn't broken or anything, but they still got a compartment syndrome due to the injury, okay? Carpal tunnel is a type of compartment syndrome. You could burn yourself, and cellulitis could set into that area, and a lot of swelling and pressure can occur in the tissue. Well, that's a type of compartment syndrome, where that swelling cuts off that circulation. Now, treatment. If you have someone with a cast, of course, we're going to loosen the cast to restore the circulation. That's right, we must restore the circulation, and we loosen it by bivalving it. And you have a picture in your book that shows a bivalved cast. Now, I want you to be careful if you ever are looking at the answer that says remove the cast. That one kind of worries me a little bit. That option worries me a little bit. It may be your only choice, though, but it should not be your first choice. Now, for me to select the answer, remove the cast, that client would have to have a really, really bad neurovascular check, okay? Now, I'm not saying that remove the cast will never be the right answer. I'm saying that if they've got a really bad neurovascular check, in other words, their hand is purple, it's numb, you don't feel a pulse, and they've got a forearm cast, if that's the only answer there that will save that arm, yes, I'm going to remove the cast. However, I would rather it say loosen the cast, okay? But you know, on NCLEX, they put me in a bind. They put me in an uncomfortable situation, one that I do not like. And I have to do whatever I can to try and save the extremity, all right? Now, orthopedic nurses have cast cutters available to loosen cast if they should need to, okay? And they can just cut around the edge and loosen the cast and restore the circulation. Now, something else you may have heard of is a cast saw that may be used to cut off a cast, okay? Now, if you're about to use a cast saw, maybe to loosen a cast or maybe to remove a cast for whatever reason, you may be removing it for something besides compartment syndrome, okay? You need to explain to the client that the cast saw is not like a regular saw. It does not touch the skin, okay? It just vibrates. That's all it does, all right? Now then, always be nice. You don't want to do anything to increase their anxiety. We're in the business of decreasing anxiety, and just by you saying the word cast saw to someone, they may get a little bit nervous. All right, now one more thing for the treatment of compartment syndrome is fasciotomy. Now, a fasciotomy is when the primary health care provider cuts down into the tissue to relieve the pressure, and therefore we're going to restore the circulation. All right, fasciotomy. The next thing we're going to talk about is cast care. Now, the most common casting materials are fiberglass and plaster of Paris. And we use these materials because they can be easily molded to support the limb. Now, let's talk about cast care with plaster of Paris cast first. Now, ice packs. You place ice packs on the sides of the cast for the first 24 hours because the cast is still wet, as you know, in the first 24 hours. The coolness from the ice packs will decrease edema. So that's why we're using the ice packs. And always treat the cast like it is wet in the first 24 hours after application, okay? Now, because you know, when it's wet, it is soft. We do not put the ice packs on top because, especially in the first 24 hours, because what could that cause? An indentation. Remember, it's still soft in the first 24 hours, and indentations are bad because they can cause a pressure sore to form underneath. We need to use our palms for the first 24 to 72 hours when you're handling the cast, okay? Because the casting material is still wet. You know, it takes 24 to 72 hours for a plaster cast to dry completely, all right? And you're going to see why that's important in just a minute. Now, don't use your fingertips when handling this cast. If you use your fingertips, what are you going to do to the cast? You're going to indent the cast. Also, keep it uncovered and allow for air drying. Now, I want you to think about that for a second. When casting material is wet, like when they first put it on, it generates heat. Well, if you've got it all covered up, can the heat escape like it needs to? No. If you've got it covered, you've got it trapped close to the tissue. I want the heat to be able to escape, don't I? You do not want to trap the heat next to the skin. That could cause damage. Now, let's do a critical thinking exercise. And let's say that you have a client that's been admitted with the chief complaint of a fractured foot. Now, initially, you are focusing on whatever their problem is at that moment in time, their chief complaint, right? Right. But you know, anytime we've got a client in the emergency department with an injured foot, you need to make sure that you ask them if they're diabetic or not, because if they're diabetic with a fractured foot, could further complications occur? Yes. Okay, so that needs to become a habit with you when you're dealing with lower extremity injuries. Always ask if they're diabetic, okay? And when you start doing things like that, you're starting to think multilogically, and that's a good thing. Now, to answer NCLEX questions, you know that you have to be able to think multilogically. Now, back to cast care. Do not rest the cast on a hard surface or sharp edge. You may rest the cast on a soft pillow, though, to decrease edema. Not a plastic one, though, because will plastic hold heat? Yes, and we do not want to hold heat in against the tissue. If they should bleed, you need to mark any breakthrough bleeding, circle the area, and date and time that site, okay? Because we want to see if that area is continuing to bleed. Is that area that you have marked getting bigger, all right? Now, once the cast is dry, we cover the cast close to the groin with plastic. We're just trying to keep it clean, that's all. And regular neurovascular checks, all right, with the 5 Ps. And what do you do first if your client reports pain? If your client reports pain, what is the first thing you should do? Neurovascular check, that's right. And if that neurovascular check is okay, can they have their pain medicine? Yes, all right. Now, most pain is relieved by elevation, cold packs, and analgesics. All right. Now, if these 3 interventions do not relieve the pain in a casted client, then you probably have a complication going on, all right? So you better be sure and do what in the next 30 minutes after you've given them that pain medicine? Reassess. Always go back and reassess. If they're still hurting, assume what? The worst. Assume your client is developing a compartment syndrome. Yes, compartment syndrome. Now, there's a few more things I want you to know about a fiberglass cast, okay? Well, they dry more quickly. They dry within 30 minutes. You know, I've already said plaster of Paris takes 24 to 72 hours, okay? So all of those interventions related to drying of a plaster cast, okay, like the ice packs and the indentations and the fingertips, those are only applicable for 30 minutes with a fiberglass cast, okay? All right, fiberglass is advantageous, though, because they're more lightweight, they're waterproof, and they're stronger than plaster cast. And you know what else? They come in tons of fun colors and prints, too, and that's what all the kids like. Now, next thing we have, X-ray imaging is better with a fiberglass cast than with plaster, so that's a good thing. All right, and fiberglass will allow the client to bear weight earlier as well. Now, the problem with this type of casting material is that it is difficult to mold and contour, all right? It's setting up more quickly is the reason for that, all right? So, but that's why you see this type of casting used primarily for simple fractures. One more thing. Let me ask you this. Do you ever let people stick things down into their cast? No, that's a big no-no, right? Now, the way they're going to get you is this. NCLEX is going to give you something that's really, really soft. Super, super soft. And they're going to say, insert into the cast to decrease itching. Are you going to fall for that? No, you are not going to fall for that. I don't care how many research studies have been done on it and how soft it is. We are not ever going to stick something in a cast, right? Right. If you've got somebody who's itching underneath the cast, about the only thing you can do is apply something cool, like a cool blow dryer, just something that will help change that sensation, alter the sensation of itching, all right? It's also like a diversional activity too. Diversional activities are good for this as well because it'll help get their mind off of the intense itching that can occur. Now then, we have traction. Let's start with some miscellaneous information about traction. First of all, traction uses a pulling force to reduce and immobilize fractures, okay? Now, when I say reduce a fracture, what do I mean? Reduce means to realign the bones, okay? Realign the bones. If you work in an emergency department, you may have an orthopedic surgeon one day that comes in and says, come on, we're going to go and reduce this fracture. Manually, they mean, which means he's just going to take his hands and do what? Pop those bones back into place. All right. The goal of traction is to reduce muscle spasm and pain. Also, realign the bones and prevent deformities. So traction is a good thing, isn't it? Now, should skeletal traction be intermittent or continuous? Continuous, okay? If it's not continuous, it's not doing any good. Here's a good rule. Never release traction unless you've got a primary health care provider's order. If you release it, what's that muscle going to do? Spasm and cause even more damage. Also, with traction, we use weights, okay? Now, the weights should hang how? Freely. They should not touch the bed. They shouldn't touch anything. They shouldn't touch the floor. And also, we have to keep the client pulled up in bed and centered with good alignment, right? Yes, especially if they've got traction, say, on one of their legs. It's going to be pulling that client down in the bed all the time, right? Because of the weight at the end. Like with Buck's traction, all right? Let's say it's attached to my right leg. Now, what is that Buck's traction constantly doing to my leg? It's pulling and constantly pulling me where? Down in the bed. That's right. Well, I have enough body weight that I can keep myself pulled up in the bed. But what about the client that weighs 90 pounds? Every time you go in the room, where is her head? In the middle of the bed. You think she's comfortable? No. So you go in and you look at her weights, and they're very, very close to touching the floor. But they're not touching it, just almost. So what do we do? How would you handle this situation? Some of y'all might have wanted to just pick up the weights, put them on the bed, and pull the little lady up in the bed and reestablish the traction. Now, you may have seen that done at the hospital, but that worries me. Now, let's talk about it. First of all, yes, I can pull this 90-pound client up in the bed by myself. But when I pull on her, what am I doing to the pounds of pressure? I'm increasing the pounds of pressure. Did the primary health care provider say I could even do that? No. They don't want you to increase the pounds of pressure by pulling that client up in the bed, because that could cause further damage, right? And the reason we don't take the weight and set it on the bed is, what did you just do to the traction? Released it. And we just said a minute ago, when you release traction, what could that muscle do? Go into a spasm. So what are we going to do? Well, if you work in orthopedics, you need some friends, okay? So you get a couple of friends to come with you. And while your friends are pulling the client up in the bed, you're lifting the traction. I didn't say release it, because we're not releasing the traction. We're lifting it up as the client is being pulled up in the bed, okay? And you just might as well go on in there every hour and reposition the client, because it's going to keep pulling her down if she doesn't weigh much. Now, unfortunately, I have seen nurses get a sheet, like a bed sheet, and they make it long and skinny, and then they tie the client up to the head of the bed like this, so they won't slide down in the bed. That is not nice. That is just totally inappropriate, okay? Yeah, it will keep her pulled up in the bed, but first of all, you just don't do things like that, right? And also, with all that pressure under the arm, that could cause brachial nerve damage. That's not good. It's just not appropriate, all right? If somebody ever tries to get you to do something as an intervention and it just doesn't feel right inside, don't do it, okay? Now, back to traction care. We need to exercise the non-immobilized joints. The rope should move freely, and the knot should be secure. And the weight should hang freely and not rest on the bed or on the floor. Sometimes they use special mattress overlays, such as air-filled or high-density foam mattresses too. All right? Now listen. Anytime you have a client who is immobile for an extended period of time, you have to worry about foot drop. Okay? Now, this can be seen in the orthopedic client, or maybe someone who has a brain injury, spinal cord injured person, anyone who is immobile for a long time, as it is at risk for foot drop, okay? Now, what are they doing these days to prevent foot drop? Well, a foot drop boot is my first choice, Or have you ever been walking down the hall of a hospital and just glance over at a room and you see a little lady sitting up in bed with her high top Adidas tennis shoes on? Yes, that kind of looks unusual, but those high top tennis shoes, or sneakers you may want to call them, do help with foot drop because it keeps that foot at a right angle. And that's good. You know, even the weight of the sheet on top of the toes can cause the feet to point. That's not good. It can also cause skin breakdown on top of the toes. All right, so be careful about those sheets. Now, types of traction. Skin traction. Use short term to relieve muscle spasms. It is used short term to relieve muscle spasms and immobilize until surgery. Okay? So when somebody has a fracture, we want to immobilize it, right? Yes, until we can get them to surgery or have that fracture repaired. Now, skin traction is when tape or a boot, splint, or some type of material is actually stuck to the skin and the weights pull against it, all right? Is the skin penetrated? No. And the most common type of skin traction is Buck's traction. It's most widely used with hip and femoral fractures, okay? Buck's traction. You've probably seen that. Now, when you have someone in this type of traction, you have got to do good skin assessments because could this traction tear my skin? Yes, because it's pulling against the skin, all right? You need to inspect the skin, especially the ankles and the Achilles tendon 3 times a day. So good skin assessments are very, very, very important, okay? And you may need to take another nurse with you to do this skin assessment because you have to maintain support of the extremity and the traction while you inspect the entire extremity, okay? Now, skeletal traction. This traction is applied directly to the bone with pins and wires. Skeletal traction is used when prolonged traction is needed. Okay? Now, underline the word prolonged. That's why we're using skeletal traction. All right, now, types of traction. Steinman pins, Crutchfield or Gardner-Well tongs, or a halo vest. And you must monitor the pin sites every 8 hours for any kind of inflammation or signs of infection. You know that pin care begins 48 to 72 hours after insertion and should be performed daily or as the physician has prescribed. Now, pin site care may vary, but it usually includes cleaning with chlorhexidine, rinsing those pins with sterile saline, and drying the area with sterile gauze. Do you have to use sterile technique? Yes, you do. You've got a pin going all the way into the bone, right? So yes, we want sterile technique. Is serous drainage okay? Yes, clear fluid is okay. Now we have a little critical thinking exercise here. Let's say you are assessing a client with Steinman pins in their leg. During your assessment, you notice that one of the pins has fallen out and it's lying on the bed. What do? Reinsert? No, you don't reinsert. If you chose that, you just became an orthopedic surgeon just like that. You don't do that. Besides, it's not sterile anymore, is it? Right. What about cover the opening? Well, nothing's wrong with that. But you know, y'all, what's the purpose of the pin? Immobilization. So you've got to do what the pin was supposed to be doing, and that's immobilize. So I want you to immobilize their leg and activate that call light and get somebody to call the primary health care provider for you and let them know what has happened, all right? That's going to be your best answer. So they're always going to put something on there like cover the hole, check the vital signs. Now, if you say check the vital signs in this critical thinking exercise, what are you telling the NCLEX lady? You're saying, I don't know what to do. Just do something. Check their blood pressure. I don't know. Cover it. Okay? But we want to fix the problem, right? None of those things fix the problem. All right. We have to pick an answer as close as we can that will fix the problem. So immobilize the leg and call the primary health care provider would be the best answer. Next, total hip replacement. Well, Buck's traction is used frequently pre-op to immobilize, all right? Pre-op to immobilize. Now let's talk about post-op care and our nursing considerations. First thing, neurovascular checks. There they are again. Also, if they have any, we need to monitor the drains, okay? Sometimes the primary health care provider will put drains around the incision to prevent fluid accumulation. These clients need a firm mattress. You know, anytime you've got somebody with an orthopedic injury or a joint problem, a firm mattress is needed for support, supporting all the joints. An overbed trapeze may be used. If they can use it, that will help build their upper body strength. They may use it to move around in the bed, keep themselves pulled up in the bed, or maybe to help them get on the bedpan or something like that. So that's a good thing. You know, they're going to need some upper body strength, right? Yes. And because, you know, when they start ambulating again, like with a walker, do they need upper body strength? Yes, they do. Let's talk about positioning. First thing, neutral rotation. And that means toes pointed to the ceiling. Now look at my hand, okay? Pretend it's a foot. If this is broken, say, let's pretend this is my hip. I know it's my shoulder, but let's pretend it's my hip, okay? And if my foot is doing this back and forth, inwardly and outwardly, am I rotating this joint? Yes, I am. Could it dislocate? Yes, and that's what I'm scared of. Also, limit flexion. We want extension of the hip. So far we have neutral rotation. That means toes pointed to the ceiling, and we're limiting the flexion, all right? We want extension. Flexion is bad, y'all, here, because it will make your hip do what? Dislocate. While I'm standing straight up and down, am I flexing or extending my hip joint? I'm extending it. When I bend over to tie my shoe, what am I doing to it? Flexing. I'm flexing my hip joint. Now, when I'm lying flat in the bed, am I extended or flexed? I'm extended. My hip joint is extended. When you start raising the head of my bed, what are you doing to my hip? You're flexing it. And we've already said flexion is bad because it will make your hip dislocate. Next question. Do you want abduction or adduction? Ab. You want the first one, legs apart, right? Yes. That's why we have an abductor pillow. Legs apart, because that helps keep that new joint together, doesn't it? It prevents dislocation. Now then, what exercise can the client do while still confined to bed? Not much, but they can do isometrics. And when I say isometrics, I mean things like squeezing those quads and glutes. And when you squeeze those muscles, what did you just do to venous return? You increased venous return. That's good. And it also helps you maintain a little muscle tone. Now, trochanter roll. What is the purpose of the trochanter roll? To prevent external rotation. Remember, we want those toes pointed to the ceiling, so you just roll up a towel or a blanket, place it along the greater trochanter, and it'll keep the foot from rotating outwardly. So we're preventing external rotation. Should you document in your nurse's notes that you had the trochanter roll in place? Yes, that's what you do. Next, no weight bearing until ordered by the primary health care provider. Now, I know some of you have had a client with a total hip and they were out of the bed that day. Well, that's great, but they may not have been weight bearing on the affected extremity that day. It just depends on the type of surgery that was performed. Next, check the prescriptions before you allow them to weight bear. Very important. Other things we have to remember here. Avoid crossing legs. Avoid bending over. These actions can cause the hip to do what? Dislocate. Now, we've talked about that a lot. Obviously, we do not want that to happen. Is it okay to sleep on the operative side? I'd rather not. I'd rather not. We've had enough pressure on that side, haven't we? Yes, on that hip. So, I would wait until the primary health care provider said that it was okay to sleep on that side. So let's wait on that. Protect that side. Is hydration important with this client? Of course, because they're immobile, aren't they? Yes, they might develop a deep vein thrombosis. And as you know, another term for DVT or deep vein thrombosis is venous thrombotic event. Another thing we have to remember here is when somebody's this immobile, pneumonia can occur. So hydration is very important for many different reasons. Is it okay to give pain meds in the operative hip? I'd rather not. I think we've had enough trauma over there for right now. Let's look at some complications of a post-op hip replacement. You know, we've mentioned dislocations several times, and that's important because that can lead to circulatory and nerve damage. Well, how do you know when something's dislocated? Well, if it's a hip, you may see shortening of that leg, abnormal rotation, or they may not be able to move the extremity. Another one you need to put a star by is pain. The next complication, infection. You know, that's why the primary health care provider put them on a prophylactic antibiotic to begin with, because we're worried about infection. You know, also, we must get rid of the Foley catheter and drains as soon as possible, right? Because those serve as a portal for introducing infection into the body. Now, I want to ask you something. Does this client now have a foreign body in their body? Yes, it's an artificial hip, isn't it? You know, anytime you have a foreign body in your body, if infection gets in the body, where does it want to go? To the foreign body. That foreign body acts like a magnet for infection. So, if you have a client with a foreign body, like an artificial hip, or maybe even a heart valve, that sort of thing, you must be very cautious about infection. You worry about infection getting into this person's body. And like I said, that foreign body acts like a magnet for bacteria, and the infection will settle in that area where the foreign body is and cause even more damage. That's why your teacher taught you that, for instance, if you have an artificial heart valve, before you go to the dentist, you have to take what? Antibiotics. That's right. Because if that person were to get an infection, where is that infection going to run to? The artificial heart valve. The foreign body. The next complication, a vascular necrosis. Well, the name says it all. The area dies because there is no what? Blood supply. We can't control that. That's just one of those terrible things that can happen. Other complications are those immobility problems that we've all studied in our very first semester of nursing school. Let's look at some client education now. What is the best exercise for this person going to be? Walking. When the primary health care provider says it's okay, all right? So we have to wait until they say it's okay. My second favorite exercise is swimming. Now, what if you have a client who is not going to go walking and they're not going to go swimming? Rocking in a rocking chair is a good answer, because if the client wants to rock, they must push off with their feet, right? That's a little isometric exercise. Something else I want you to remember, avoid flexion. Now, we've said that over and over. Now, look at all of these things we have listed for you. Things that cause flexion: low chairs, traveling long distances, sitting more than 30 minutes, lifting heavy objects, excessive bending, twisting, stair climbing. Now, I emphasize this with hip clients, all right? Avoid flexion. All of those things will make you flex, and flexion is bad because it makes you do what? I heard you, dislocate. Now then, we're going to look at amputations, and we've got some miscellaneous information first. Amputations are performed at the most distal point that will heal, all right? The most distal point. The surgeon tries to preserve the knee and or elbow if they can, all right? Because, you know, if you've got your knee joint, when I get my prosthesis, all right, and I begin to walk, my gait will appear more normal if I have my knee joint. Same thing with my elbow. I'll have better use of my prosthesis, won't I, if I have my elbow? So they do try to preserve those two joints if possible. Now, immediate post-op care. What are we going to keep at the bedside? A tourniquet in case of massive hemorrhage. Tourniquet in case of massive hemorrhage. Now, you may have heard someone say that you never use a tourniquet on a hemorrhaging stump because it will cause too much soft tissue trauma. Now, then I want you to think about that for a second. If you are hemorrhaging, I said hemorrhage, I didn't say a little blood. I said if you are hemorrhaging out of your stump, do you really care about soft tissue trauma right now? No. You'd prefer to stop the bleeding, wouldn't you? Yes. If you can stop the bleeding, you can deal with the soft tissue trauma later, can't you? Yes, think about what's priority. We're trying to keep people alive, aren't we? Yes. Also, how do we prevent hip and knee contractures? Well, the word that will prevent a contracture is this: extension. Extension. All right, now look at my arm here. When I'm folding my arm in like this, what am I doing to this joint? I'm flexing, right? I'm making the angle smaller. When my arm is straight, I am extending. If you extend joints, you're going to help prevent contractures. So extension is good for contractures. Now, inspect the residual limb daily to be sure that it lies completely flat on the bed. You may even see a light sandbag placed on top of the limb to keep it flat, especially when you're dealing with below the knee amputation or something like that, a lower extremity amputation. So, what if I have a below the knee amputation? A BKA it's sometimes referred to. You have to worry about the client forming a contracture in two places. Remember, it's below the knee. What are the two areas you worry about forming a contracture? The hip and the knee. The hip and the knee. So, keeping that in mind, what would be a good position to make this client get into 3 or 4 times a day that would force the hip and the knee to extend, straighten out? What would you think? Prone position. Prone. Put the client on the stomach to extend those joints. Extend those joints. That will help prevent contractures. Now, phantom pain. First of all, is it real? It's real to the client, and that's all that matters. You know that we are never supposed to be judgmental of people's pain, right? Right. Now, what is the first intervention to decrease phantom pain? Diversional activity. Diversional activity. Try to get their mind off of it. But are they going to get pain medicine too? Yes, they will get pain medicine because the pain is real to them. But if you had to pick, which one would you select first, diversional activity or pain medicine? Of course, diversional activity. We always go with the least invasive first, right? Yes, we're going to avoid medicine as long as we can on NCLEX, all right? That doesn't mean we're going to withhold medicine. That means we're going to try other things first, depending on the severity of the pain. Now, that's why I've got to use diversional activity here in an effort to get their mind off of it. And if that doesn't work, we're going to the medicine then. All right? Just show them that you're going to try something else first before you go to medicine every single time. That makes everyone so happy. Now, phantom pain is seen more with above-the-knee amputations, and it usually subsides in 3 months. Now, in some people, it never goes away. They always had the feeling that the extremity or maybe their finger, the digit, whatever it is still there. So sometimes it never goes away. Now, you will see your NCLEX tip there on your handout. With pain, use other things first prior to medication. You know, the definition of pain is whatever the client says it is. Always assess the client's pain by having them rate the pain on a pain scale, like a pain scale of 0 to 10. And finally, rehab. Now, why is limb shaping so important? Why do we want it shaped a certain way? For the prosthesis. For the prosthesis. And how do we want the stump to be shaped? We're talking about the end of the stump. It needs to be shaped like a cone, okay? A cone shape, which just means it's smaller and more rounded on the bottom than the top, all right? smaller and rounded on the end so it will fit down into the prosthesis better. Now, what is worn under the prosthesis? A limb sock. A limb sock. Now, when I first come back from surgery, after I've had my amputation, I'm going to have a really tight compression bandage on, aren't I? Yes. And the purpose of that really tight compression bandage is to decrease hemorrhage and decrease edema. But 2 weeks later, I've still got this compression sock on. But 2 weeks later, the purpose of it has changed. You know, I said initially it was to hold pressure, right? Decrease bleeding. But now, 2 weeks later, it's for shaping. We're trying to shape the stump. All right. Why is it important to strengthen the upper body? Because with an amputation, I'm probably going to be using crutches or a walker. And for those things, do I need upper body strength? Yes, I do. Initially, I may be using those things. I'm not saying that they'll have to use those things forever, but initially, possibly. Is it okay to massage the stump? Yes, it is okay. Now, normally, we do not like the thought of massaging an extremity because we're scared we may dislodge a clot. But here, it's okay because it promotes circulation and decreases tenderness. Promotes circulation and decreases tenderness. Now, how do I teach a client to toughen the stump? Well, first of all, why do I care if the stump is tough? For the prosthesis. For the prosthesis. So this is what we teach. First of all, we have them press into a soft pillow for a period of time. Then a firm pillow. Then the bed. And then a chair. And you're saying to yourself right now, I have never seen that done. Well, I haven't either. But at least we're going to get it right on NCLEX, aren't we? Yes, we are. You know, the only time they even do this is on an outpatient basis, okay? And they're already gone home and you're not seeing them there. How do you walk with a walker? Teach yourself right now the proper way to walk with a walker. Do you know? Well, you're supposed to put the walker a little bit in front of you. Not way out in front, a little bit. And then the person is supposed to walk into the walker. Do people do that? Not usually. Have you ever seen the galloping walker person coming down the hall at the nursing home? Okay, that's dangerous. When they gallop with the walker, they could fall, right? Or some people even pick up their walker and walk over here to visit their friend. And then put it down and visit a little while. And they pick it up and walk somewhere else to visit with somebody else. That's not right, okay? You're supposed to pick it up, put it a little in front, walk into it, okay? That's the safest thing to do. Now, sometimes you've got people who have so little upper body strength, they can't even pick up the walker. You know, you and I can pick it up with one finger, can't we? Well, if you've got somebody that's that weak, all right, you may see them put tennis balls underneath. Now, some people are saying right now, what about rollers? Can they have little wheels on their walker? Well, that scares me because could that be dangerous? Yes, it can be dangerous, all right? The tennis balls make me feel better because it allows the walker to slide more easily. They don't have to pick it up all the time, okay? You can also use the tennis balls if you have somebody with a shuffling gait. That will help them as well. Now, crutches. You know, when you need crutches, are you supposed to go and borrow your friend's crutches so you won't have to buy any? No. You're supposed to buy your own crutches so they can be fitted properly. Now, when you're thinking about them being fitted, do you want them to be the top of the crutch I'm talking now? Do you want the top of that crutch to be really tight up under the arm? No. The crutch should be 1 to 2 inches below the axilla. 1 to 2 inches below the axilla, or, you know, if it's pressing up too much underneath your arm, you're going to get brachial nerve damage. Brachial nerve damage, and that's not good. Now, we've all seen somebody somewhere that had borrowed somebody's crutches, right? And they don't fit right. Or when you're resting, are you supposed to rest your arm underneath your arm on top of the crutch really hard? No, not at all. You're supposed to rest your body weight on your hands, okay? All right, not on your axilla. That can cause damage. Now, stairs. If you have crutches, when you are walking up and down the stairs, it's up with the good and down with the bad. That's the rule. Up with the good and down with the bad. That's the rule you need to remember for walking with crutches up and down the stairs. Okay, you're going to lead up the stairs with the good leg and down the stairs with the bad leg. Or you better take the elevator, all right? Right. Now, if I'm walking with a cane and I've had a stroke on the left side of my brain, it's going to be hard for me to hold the cane with my right hand, isn't it? Because my right hand, my right side is what's going to be weak if I've had a left-sided injury over here, right? That's right. That's why they always say to use the strong side with your cane. I always use the strong side. Now, because I have to have a strong hand to hold it, don't I? Yes. Now, here's a rule. A cane should be used on the strong side of the body. It's just that simple. All right. That's it for orthopedics. Thank you.